Namaskar, I am Dr. K. Agarwal. Welcome to our regular webcast. And this time we are discussing an important subject. It's a subject which is of importance not only to doctors, GPs, but also to the general public. And the subject is CT scan versus MRI scan. When should we go for CT? When should we go for MRI? If you choose an MRI, which Tesla MRI? And if you choose a CT, which type of a CT scan? What about radiations? So all those things we'll be talking in the next half an hour. And I have with me Director of Dr. Gulati Imaging Center, Dr. Praveen Gulati, who is also a member of technical committee in the NABH and also a ethics committee member of JNU. Welcome to our show.
Thank you, sir.
If I see most of the time the dispute is that MRI was done unnecessarily, CT scan was done unnecessarily, and there is a people are doing CT and MRI only because to earn money or to get cuts and commissions. So we need to answer all these questions in the next half an hour. And we also need to know about the new policy, specifically IMA policy, which talks about that we should accumulate radiations, and if it is not necessary, CTs, any radiation should not be done. So what is the basic difference between CT and MRI?
Thank you, Dr. Agarwal, for the invitation. There's a basic difference between CT and MR as far as technology is concerned. Now, CT is totally X-ray based imaging modality, in which the character of the image will depend upon the attenuation of the X-ray beam. That means more the attenuation, like in bones, you will see it as a bright. The lesser the attenuation, you will see it as dark, like in lungs, you see dark. The image formation of MR is more complex. I will not go into details, but just to give you a very short impression about that, you know, our body has a lot of protons in it. Under normal circumstances, when we are sitting here, these protons are just moving haywire and our magnetization is zero. We are not imagining. But just imagine when we place our body in a very strong magnetic field, what will happen? These protons, they will align parallel or anti-parallel to that strong magnetic field. So a state of magnetization, state of equilibrium is attained. That doesn't serve any purpose. Now we start giving weak RF pulses, those radio waves. Those are the sound which you hear when you're doing the MR scan. Now when you give this RF pulses, these protons which were lying quietly, they will move to higher energy state level. Now we switch off this pulse. So these protons, they will try to come back to the original status. And during this process, they will emit the energy which they had required. Now this energy forms the basic MR signal. That's in a very nutshell how the MR image is formed. Now depending upon the number of protons, depending upon the environment in which they are situated, and depending upon what type of RF pulse you are given, how frequently you are given, how frequently you are picking up the signal, the image character will vary. So in X-ray, the image character depends upon one factor, that is attenuation of the X-rays. In MR, image formation depends upon number of factors. So that's a very big advantage of MR, and there's a difference between two. Now CT is basically an X-ray based modality, so we are using radiation. While MR, we are not using any radiation. It's only an interaction of our body protons with a strong magnetic field.
So like we all know X-rays are ionizing radiations. There is a limit. Okay, you need to count down your limit. There is a background ionizing radiation and there is an exposed ionizing radiation. So this magnetic field is absolutely safe.
The magnetic field which has been approved by FDA, that is totally safe for human body. So much so that even during pregnancy we are doing it. So magnetic field is no harm. Like till now, we are doing 3 Tesla which is approved by the FDA for human beings. But work is going on for 7 Tesla, 9.4 Tesla, but they are yet to be used for the human beings. They are being used on the experimental purposes, and it's still in use for the research work and for the animals. So maybe in near future, even the 7 Tesla and 9.4, once they have been proven safe for human bodies, they will come into practice.
What do you mean by Tesla?
Tesla is the strength of the magnet. Right? Now, if see, our Earth also has a magnetic field. Now we talk about 0.5 Tesla, 1 Tesla, 1.5, 3 Tesla. That means the magnetic strength is going up. Like a 3 Tesla magnet will have a magnetic strength equivalent to 60,000 magnetic field of the Earth. So that's how we correlate to that. Basically, it tells you about the strength of the magnet.
So higher the Tesla, higher will be the quality of the picture.
That's right to a certain extent, but there are number of other factors which also impact the image quality. But yes, as you increase the strength of the magnet, the signal which gets generated that improves. So the signal you will get on 3 Tesla will be practically double the signal you get on 1.5 Tesla. Right? So naturally, as you improve the magnetic strength, the signal you are getting, the image quality you are getting, that definitely improves.
So which are the conditions? Okay, we'll come back here. Let us first define when to do CT, when to do MRI.
That's a very pertinent question, and I think even today in a city like Delhi also, every day we have one or two questions where at least I don't agree that this investigation has been asked for. In very important pathology which we come in our day-to-day practice, I'll start with the head. In head, there are two situations definitely where you should ask for a plain CT head. Don't ask for MR in that. Number one is trauma. Number two is acute stroke. And number three also I will add is a sudden onset of acute headache where you want to exclude subarachnoid hemorrhage. These three conditions, the first modality of choice remains is a plain CT scan of the head. Now what about the other situations? In most of the other situations, like even stroke, if the patient starts developing gradually increasing weakness of any part of the body, then you should ask for MR. One condition which is very common in our country, that is epilepsy. Now epilepsy I have seen, because epilepsy the patients go to GPs, patients go at every level because the number of patients is so high. In epilepsy, the first investigation should be MR, because you will first ask for a CT scan. You may or may not get something. The lesion is there, will not get characterized. So you will ask the patient again to go for MR. So patient is practically spending double the amount of money. So in situation of epilepsy, always ask for an MR. And here again, I would like to emphasize that even in epilepsy, number of times you see the clinician has written epilepsy MR brain. Now in most of the centers, the doctor is not sitting here, technology is sitting there, he just sees MRI brain, he will do a routine MR brain. Now routine MR of the brain can miss number of lesions. Why I am emphasizing epilepsy is because it's a day-to-day problem, very common problem. While for evaluation of epilepsy with MR, we need specific protocols. We have to look certain areas in greater detail. So my request to all of you is that whenever you ask for MR for an epileptic patient, always specify that we want MR for epilepsy, so that the radiologist, the technician can use the epilepsy protocol. Then we come on to other situations. The patients having visual problem, patient having say hearing problem, or any pathology which is you are suspecting in relation to brain stem, in relation to cerebellum, in CV junction area, all those areas MR remains the modality of choice. Patient having chronic type of headache, again I said for acute headache ask for a CT scan, because we want to exclude subarachnoid hemorrhage, very important. For chronic headache, go for MR. So you have to be very selective, and in case you have any doubt, never hesitate to talk to your radiologist. That's my request. Then moving on to the other parts.
So as of now, for brain, except for acute stroke, acute headache, and acute head injury, in all other situations, MRI is the investigation of choice. So remember the word acute: acute stroke, acute headache, and acute head injury.
That's it. Moving on to the areas concerned to the ENT surgeon. Like paranasal sinuses is another area where we get very frequent requests for investigation. Now for paranasal sinuses, CT scan is the modality of choice. Temporal bone evaluation, CT scan is the modality of choice. There are situations which I will not go into details because of the time. There are situations where definitely MR has to be asked for even in these areas. But the first investigation, like when you are suspecting sinusitis, you want to look for the paranasal sinuses, you look for temporal bone, middle ear cavity, CT should be the initial investigation of choice. Moving on to the chest, that's another part. Now, chest is one area where primarily it is the lungs. Now, lungs have air. So, naturally, when there is air, protons are less. So, MR will not give you much of a signal. So, for evaluation of the lung fields, CT is the modality of choice. Mediastinum, again, we take into the chest, and primary modality remains
So,
the
up till now we are talking about air, bone, and blood.
air, bone.
Air, bone, and blood.
Blood is acute blood, clotted blood.
Yes.
There,
So, wherever you want to see acute blood, air is there, or a bony lesion is there. Lopacity.
lupus.
Okay.
In most, that's a general state.
General state. We are talking about
There
general
are,
state.
of course, exceptions to everything. Moving on to the mediastinum. For mediastinum, CT and MR both are equal, but as things stand today, most of the time the first modality remains a contrast enhanced CT. Right? Then we come to the lower in the abdomen. In abdomen, for all bowel pathologies, CT is the modality of choice. It has to be done with contrast. Contrast has to be oral as well as intravenous. Now, oral contrast can be positive or negative. That means different type of contrast are there. As far as the liver is concerned, for looking at the pancreatico-biliary ductal system, you know there is a condition MRCP, there is a modality. Now, MRCP is the modality of choice. Now, MRCP will provide you the complete tree of the biliary tract, of the pancreatic duct, without giving any contrast to the patient, without causing any discomfort to the patient. And I feel all patients with polylithiasis, before going for a lab poly, we should always ask for MR. Then the chronic liver diseases. In chronic liver diseases, again, MR has been found to be superior lately as compared to the CT scan. Pelvis is one area where I would like to emphasize that pelvis, even today, even in city like Delhi, a lot of gynecologists ask for CT scan. Pelvis, female pelvis, all gynecological malignancies, the modality of choice is MR and not the CT. The amount of information which you will get on MR is much superior as compared to CT. The reason is simple. You will get multiplanar, the soft tissue contrast is much better. So the uterine system, endometrial cavity, cervix, everything will be much better seen on MR as compared to the CT scan. Similarly, for the male pelvis, like prostate. Now for prostate, again, don't ask for CT, ask for an MR. And especially now we have multi-parametric type of MR, especially to look for early CA prostate. So that's a situation where again MR scores over CT. Now when you want to look for the renal stones, then CT becomes better. Renal stone, ureteric stone, then CT becomes better. The other important area of the body is the musculoskeletal system, the joints, knee joint, shoulder joint. There, because you are looking, if you want to look inside the joint, you want to look for the menisci, you want to look for the ligaments, the soft tissues, their MR is better. Whether it is knee joint or shoulder or wrist. In wrist, you want to look for the carpal tunnel, you want to look for any ligaments, MR scores over CT. If the main cause of concern is the trauma, again for bony trauma, then CT scores over MR. So this is in a nutshell, but I would also like to share with you, there is a site, choose wisely. If you have any confusion on the net, you can see choose wisely. That's a site from the ACR, and you can find their elaborated number of clinical conditions. You can see from there which is the best modality.
So, Choose Wisely is a site which talks about all aspects of medicine, including radiology, and it talks about 5 main conditions, specifically the condition in which investigation to use and which investigation not to use. For example, it talks about backache, and when the backache is of more than 2 weeks, there is no need for getting any radiological investigation done. So if I have to summarize as an MBBS doctor who is watching this program, say if you are looking for air, so sinuses, GI tract, wherever lungs, CT scan needs to be done. If you're looking for a bony lesion, again CT scan needs to be done. Whether it is sinuses, whether it is brain injury, you need to have. And whenever you want to rule out a blood from anywhere, acute hemorrhage, then you need to do a CT scan. So therefore, acute trauma in the head, acute bleeding in the head, which is a subarachnoid hemorrhage, or then acute stroke, and then sinuses, and then you go back to the lungs, and then you go back to the GI, where CT scan is invariably better than MRI. In all other situations, MRI is better. So this is not a question of money. that if money is equal, if CT scan and MRI cost the same, then which investigation will be done? It shouldn't happen because MRI is costly, therefore we are getting it done. CT, we are getting it done for the purpose where it is cheaper. No, CT has distinct advantages even if it is cheaper in these situations. Now we come back to radiations in CT versus MRI. MRI, we said there are no radiations. It can be given in pregnancies. So if I want to go for, suppose I want to say patient needs to have a minimum radiations. How do I do?
Uh, I would like to tell you one thing that in a study carried out in America, it was seen that after the introduction of CT scan, the average amount of radiation has increased up to 6-fold. And of the 6-fold, 40% is attributed to CT. Rest is because of increasing number of international procedures. And this radiation is a very important aspect because, especially in our country, where leave aside the general public, even doctors themselves do not take care of the radiation fraction. I know gastroenterologists, I know cardiologists who have suffered radiation injuries because they were not careful while carrying out the interventional procedures. So it's very important that we should keep the radiation aspect in our mind. Now, what precautions we can take is, first of all, whenever you are asking for CT scan, you should ask few questions from yourself, whether as a doctor or as a
Is
patient.
it needed?
Number one is it justified?
Can it be replaced by ultrasound and MRI?
Exactly. Can it be replaced with some non-ionizing based modality, ultrasound or MR? Second thing is it required just now, or we can wait for some more time? Then comes the important question. The important question is from where you get it done, because it was again in a study seen that the same CT scan, same abdominal CT scan, one person does, he gives 4 millisievert. The other person does, he gives 20 millisievert. This much of the range of radiation has been seen.
That is protocol.
Variable. That is a protocol.
That is the protocol.
That is a protocol. So very important thing is the person who is doing it. The equipment which you are using, it should be ARB approved. Right? Then it should have a quality assurance test done on regular intervals. And I will go a step further, preferably the center where you want to get done should be NABH accredited or accredited by any other organization. Because only then people, that's the mentality that only then people take care of
So
it.
as a common man, let me have few parameters. My first parameter is that will 64 versus 128 versus 60 versus 256 will, apart from increasing the speed, will it also reduce radiation?
That's a very important question. See, it's not only the amount of radiation, you are increasing the cost of investigation.
So let's forget about the cost at the moment.
Yeah.
I'm only talking about this. Normally we go higher number for the purpose of heart, a beating heart. But in a routine CT scan, will the radiation level differ from a spiral CT versus 128 CT?
The highly advanced 128 slice to 6 slice CTs nowadays which we get, they give you relatively lower amount of radiation. There are two things.
Is it significant enough?
Depends upon the equipment you are using. There are newer equipments, they are using specific measures. They have changed the mode, the images are reconstructed. Right? That makes a lot of difference. Earlier we were using filter back projection type of reconstruction. Their amount of radiation you are using to create one particular type of image was more. Now you are using different type of
My question is very simple. I have a person who is radiation conscious. Okay, money is not an issue to him. He wants, I must write down on my prescription how much radiation has been used. He wants that number.
Yeah.
And I know that every machine can give that number. How much radiation has been exposed to that person. And he says, I want minimum radiation to be exposed.
Yeah.
So therefore, as a GP, I need to refer him. Okay, one way of referring is that minimum radiation protocol, and let the radiologist decide.
Yeah.
Second is the GP must know what is that protocol. So he writes down that I want to be done with this particular type of a machine or this technology. So therefore my question again comes back. that we know that the speed of CT scan, say 126 slides per second versus 64 slides per second, will it also change the amount of radiation significantly? Answer is yes or no.
The answer is yes. If you go for the higher system, the amount of radiation given to the patient will be relatively less. That's in a simple word. But now there is this second question which we must keep in mind when we're talking in our Indian context. See, on this two systems, as I said earlier, the protocols which we are using.
What is that protocol that is called as low radiation protocol?
In low radiation protocol, the amount of kV, amount of MAS you are using, that should be low. You are using less. So what I point one term, that we as a radiologist, we should go for a diagnostic image. We should not go for a beautiful image. Because to improve the image quality or to look the image more beautiful, at times people start using higher radiation. That's not correct. So the protocols should be such that you are giving the diagnosis by using minimum parameters to the patient.
So there comes the role of a clinical radiologist. There are radiologists and there are clinical radiologists, like there are technical echocardiographers and there are clinical echocardiographers. So similarly, there are technical MRI specialists and clinical MRI specialists. Those doctors who understand, who interpret more, they would like to know what they are looking for. So they can decide, oh, I want to rule out only hemorrhage. Then why go into an image and expose the patient to a greater extent? So therefore, like in angiography to reduce the radiation, they just do a screening shot and if they see screening shot is normal, they don't take further shots. They don't have to show it in a picture to the patient that I have gone through and seen every aspect of the artery. So similarly, what Dr. Gulati is saying is that we as a general practitioner, when we are following a patient, our job is what are we looking for? It shouldn't be a blank. Pain in abdomen, so get a CT scan done. And the radiologist to decide what is there any abnormal or not. You need to know what you are looking for, and so that minimum radiations can be done.
That's right. Yeah. So what my this thing is, whenever you are referring a patient or whenever the patient goes to a CT scan center, he should keep few things in mind. Number one, the type of equipment. Number two, the technologist who is doing it, whether he is well versed with two principles. There are two principles we follow. One is LRA. LRA is as low as reasonably achievable. That's very important that we should be following these whenever we are doing a CT scan. Second is ORP, optimizing radiation protection. So these two principles should be followed in the center where patients are being referred for the CT scan. And then I already said that you should be justifying that why CT scan is being done. Another thing which I would like to emphasize is to cut down on the radiation to the patient is a lot of patients require follow-up scans. Now, when the patient is being referred for follow-up scan, always give a clinical detail so that the radiologist or the technologist can limit the study only to that particular area, so that he doesn't have to again do the entire scan. Again, that will cut down on the amount of radiation. This is about the patient. Now, the center should also take care about the attendance and the general public in general. So he has to be, the center should be careful about the radiation leakage around it, the exposure to the workers, because workers, they get exposed to radiation very fast. So whether the radiation to the individual is being monitored or not. Now you touched a very important point, and in fact we were discussing even with AARP people. What I feel ultimately a time will come when government should link our Aadhaar card with the amount of radiation an individual is. Whenever a patient gets exposed to an X-ray or CT or anything where radiation is there, that amount of radiation should come to his Aadhaar card. So that in radiation we must keep in mind, it is not only one this thing, it also has a cumulative effect. Now one thing which has been proven beyond doubt, that a cumulative dose of say about 100 milligram, when it exceeds this limit, it definitely has some increase in the carcinogenic. So we have to know the cumulative disease, the cumulative dose one the individual receives. So for that, like you said, that every investigation we do, it should be made mandatory by IMA or by the government of India, that in every CT scan, at the end of the report, how much radiation has been given to the patient, that should be mentioned. And this is possible on the newer equipment. And government should make it mandatory.
So remember, there are four types of patients. Ignorant patients, they believe in you. And then there are patients who are informed. And there are people who are empowered. And there are people who are enlightened. The patients who are enlightened, they want to know everything. They will be better informed than even most of us. So these are the people who wants to know that why did you refer me to a particular place where the radiation level was high. They may come back after 3 months and say that go back and tell me how much radiation was given and why a low radiation protocol was not followed. Time to wake up, not only for the radiologists, not only for the technicians, but also for the general doctors. They need to know our duty is say no to CT scan in situations other than when you want to look for acute blood, bony injury, or wherever there is air present. Ask yourself, do I need an ultrasound? Do I need an MRI? And if you find that you need a CT scan, do I need a plain CT scan or a CT scan with a contrast? So that twice the patient is not billed and twice the patient is not given radiations. And if CT needs to be done, how can I help my patient by minimal exposure to the radiation? And that can only be done when you discuss with the radiologist what are you looking for. It should not be a blind method to check it out. But yes, there is a situation, and with that situation I'm going to end, and that will be my last question to Dr. Gulati. There is a situation, radiation doesn't matter. You can do as much radiation as possible in that particular situation, and that is a virtual CT scan, virtual postmortem. If you are trying to find out the cause of death, instead of doing a full postmortem, you can go for a whole body CT scan to find out the cause of death. Is it not? It is still being talked about, it is feasible, and we should be able to do it. Last comments.
I think in this type of situation, definitely radiation does not make a difference. Not only that, even we have to weigh the pros and the cons. Whenever we are decided about the modality, radiation is a secondary thing. We have to see, suppose if the advantage we are getting, the information we are getting is more than the risk we can take, then definitely we have to.
I'm talking about a dead body, but person was right.
That I already
So-
said.
so
There
if
it doesn't make a difference.
If a person
Yeah,
who has
there-
died, though the best is virtual MRI, but that may take a lot of time in screening the whole body. It may take a lot of time.
There doesn't make a difference.
But then virtual CT can be done in 3 minutes, the whole body.
We should keep one thing in mind, that radiation, it is not only giving you to the body.
I
You
know.
have to take precautions for the
Others,
person.
I can understand.
Yeah.
That I can understand. But there you don't have to.
Yeah.
The body is not
Not for the
moving.
individual, not for the body.
The body is not moving. So therefore, all the persons can be out.
Yeah.
So you can do a fast protocol of a screening the whole body
That's
as a post-mortem
That-
virtual CT scan. Though a virtual CT plus MRI is the post-mortem of choice in the West, they do both.
I get it.
They do both, but at least virtual CT can start in the country. So that's all for today. We will let's thank Dr. Tawil to be here with us. And if you have any questions, you can post it to the other Facebook account. And if you like it, kindly share it with the people, because the more people will share it, the more it will be useful to the society. Thank you very much for watching this program. We will come back with one more program next